Hi, I'm Dawn Eichenfield. I am one of the pediatric dermatologists at Rady Children's Hospital. I also have an acne clinic at UCSD. It's my only adult clinic. Otherwise, I'm peds derm all the way. So today I'm going to talk about the intricacies of acne and acne mimics in kids. I have no disclosures that are relevant, but the Dermatology Foundation has supported my career, and so have my kids. So, kids today, they have one more thing that they can now blame their parents for. A recent study looking at genome-wide association meta-analysis has identified 29 new acne susceptibility loci. So they looked at over 20,000 patients, and they found that acne is now associated with hormones, hormone-sensitive cancers, and also psychiatric traits. So what does this mean about causes of acne? Well, a recent epidemiological study looking at a systematic review showed that there are lots of different things that are associated with bad acne. So these authors looked at epidemiology around the world, and they investigated factors that significantly modify the risk of getting really bad acne. What was really awesome about this paper was that they had these beautiful charts, so you can look at everything in this chart. There's like age and sex and whether or not they ate popcorn, and then it gave you a reference, and it also gave you a odds ratio of whether or not it was associated with acne. So it was pretty cool. And then what they found was that there was a strong association with family history, older teens, overweight BMI, and skin type oily. Stuff that they did not find a good association with was dietary factors and also smoking, which was less clear and inconsistent. So what does this mean? I'm kind of confused still. Well, to put it down easily, severe acne is heritable. So a recent article in Pediatric Dermatology that came out of our group actually showed that with patients who have bad acne, they will often have adult family members who have bad acne. So they looked at 101 subjects and their adult family members. What they looked at was like historical acne, so that the family had to say, oh, did you have acne or not? And they also looked at examination acne, so the patients who actually had acne. Generally, the age of onset of these patients were age 12. The severe age of onset was age 14, and most of the acne was on the face. What they found was more than 50% of patients who had severe acne had a family member also with severe acne. And then most of these patients, if not all of them, had hemorrhagic lesions. So what hemorrhagic lesions means, it means like acne fulminans-like lesions, like the really bad ones that get all crusted and crazy. So there are also a lot of new developments in topical acne therapy that I'll touch on very, very briefly, and we have lots of other good stuff coming. So first of all, let's talk about some new formulations of oldies but goodies. So let's look at what has now been FDA approved for ages 9+. So first of all, we have tretinoin 0.05% lotion. It's well tolerated. No one discontinued the medicine in the studies. There's tazarotene 0.045% lotion, which was similar in efficacy to tazarotene 0.1% cream, but much better tolerated. And then there's tretinoin BP 3%, which is really cool because it's like the follow-up to adapalene BP, which is the only other dual one that's currently on the market. And then there are some newbies. Let's look at the newbies. First of all, they are all, except for one of them, approved for ages 9+. We have trifarotene, 0.005%. It has been FDA approved for the face and the trunk. It targets RAR gamma, which is the first of its class. Nothing else targets RAR gamma so far. There is minocycline 4% foam. It's really cool because we haven't had a topical antibiotic in a while. And then finally, there's clascoterone 1%, which is the first medicine in its class to be an anti-hormonal agent, let's call it. So it's very interesting. This one, of course, is only approved for 12+, which makes sense because you're not going to be seeing a lot of kids with hormonal acne that are less than 12. If they are, you should probably work them up for some other things. So let's also talk about oldies but goodies. We really can't have an acne talk without talking about isotretinoin. So I find that the hardest part about talking about isotretinoin is all of the side effects. So generally I sit there for like 5 to 10 minutes telling my patient about the 20 plus things that might happen to them, but probably won't happen to them. And most of the time, I think they only hear, I'm gonna get dry, or maybe I'll hurt a little bit. So this was a study that also came out of our group at Rady. This looked at 25 patients who were aged 15 and 32 years. 11 of them got traditional counseling, which is like me talking to them, and then 14 of them got video-based counseling. And you can actually see the video, it's in the top right corners with this guy with the blue shirt talking to one of the providers at UCSD. And they actually, after they saw the video, they got this questionnaire and they answer these questions, and they found that people who got the video answer the questions a lot better. There was like much better comprehension with the video than with people talking to them, which makes a lot of sense. I think in today's technological advancements and stuff like that, everything gets captured a lot better with videos. Like our attention span's a little bit shorter. My young kids love to watch videos, they hate to listen to me, so I totally understand this. So let's talk a little bit about some esoteric side effects of isotretinoin. So one of them that I don't know if you guys counsel about, but I sometimes counsel about this, premature epiphyseal closure. So this is sometimes what's keeping us from putting our super young kids on isotretinoin. So this was a literature review that was done not too long ago. It looked at all of the cases of epiphyseal closure in kids, and it also looked at the FDA drug reporting database. So what they found was in patients who were under 18 years old with premature epiphyseal closure or growth plate damage, they found 41 reports worldwide from the FDA, and they saw 9 case reports with various durations and doses. So the range was between 0.5 to 3.5 mg per kg per day for a few months to a couple of years. What's really interesting is that there were 2 cases where it was acne related. I think it was 0.5 mg per kg per day for 6 months and 0.75 mg per kg per day for 6 months, which is kind of what we give our patients. So I think the take-home message from this article is that we really don't have a great cause and effect relationship at this point. It is still something that we should counsel our patients with if they're at risk of this, and you have to weigh the risks and benefits, of course. On the brighter side, isotretinoin does work well for patients who have higher BMI. So this is something we probably already noticed in our clinics, but there's a study about it now. So in the JAD, it was published not too long ago. They looked at 550 patients. About 100 of them were overweight, 82 were obese, and they looked at whether or not they were like different or similar to normal patients. And what they found were that the overweight and obese patients had elevated triglycerides and AST, but it wasn't really clinically meaningful. They may have had a little bit more headaches, maybe longer treatments and lower cumulative doses, which isn't too surprising when you think about it. But when you look at acne clearance and recurrence, it was actually very similar to patients with normal BMI. So the take home is isotretinoin works. It's so far still our best medicine after you counsel about the 20 plus side effects, of course. Okay, we're gonna take a little commercial break. I'm sure all of you guys love to go on TikTok. I went on TikTok one day and I learned a little bit about satisfying pimple popping. I don't pop my pimples, but I learned about it. I learned about how to cover up my acne with makeup. And I also learned that a lot of my patients are getting a lot of information from TikTok. So basically, today's generation learns a lot from TikTok. You guys probably know this better than I do. I'm not really in with it anymore. But they learn about acne scars, they learn about treatments, they actually get all of their medicine, like risks and stuff like that from TikTok too. It's really interesting. So there are some very positive acne influencers on TikTok, but there are also some very negative people. So there are people who call each other like pizza face, which is really bad. So it's just something to be aware of. And also you can be aware about this video. There's a video called Accutane Check There was actually a soundtrack that was created in 2019, kind of before the onset of the pandemic, and then it got widespread popularity. So at March of 2020, there were over 4,000 TikTok videos that were created with the soundtracks. Because of this, they wrote this article. So they looked at the top 50 TikTok videos that had over 18 million likes and 137,000 comments. And the videos usually focused on before and after improvement in acne severity, which makes sense. Everyone wants to see before and after pictures of isotretinoin. And then some of them, the comments actually discuss the side effects and some personal anecdotes. So there's a word cloud to the right of the screen that you can see talking about some of the common themes, like acne. Of course, everyone calls it Accutane, even though Accutane really doesn't exist anymore. People talk about side effects. There's the word doctor somewhere there. There's the word dryness. So these are the common themes that we're seeing people talk about on TikTok. About 96% of the patients describe their experiences, which is good. Only 24% described duration of treatment, and 20% described their side effects of the medication. So generally with TikTok, you're going to get some pluses and minuses, but you're still going to have to adequately counsel your patients about side effects because TikTok does not seem to be really good at counseling patients about side effects. Okay, so other than TikTok, what else is going on the internet? So I'm sure a lot of people know about Curology. It's mostly topicals that are kind of prescription-y that people prescribe on the internet, and sometimes they do antibiotics too. There are a lot of other websites now. There is Apostrophe. So this actually gives you antibiotics and spironolactone. So you can get both antibiotics and spironolactone on the internet as a prescription now. You don't need to go see a doctor in a clinic, and they don't prescribe isotretinoin yet. So when I looked online, I couldn't find anywhere where I can get myself some isotretinoin without going to see someone in person, but it might happen one day, so it's just something to be aware of. I did have a patient who walked into my clinic who was on an oral contraceptive agent and spironolactone, and they got it all from an online system. So this is happening. This is the new medicine, and we need to be aware of it. We need to know how to handle it. Let's change gears just a little bit. So we're going to talk now about this 16-year-old girl. She has worsening acne. She also regularly waxes the hair on her face and notes that her acne flares with her periods. So what is this? If you said hormonal acne, you are correct. So hormonal acne, we traditionally have thought about it as acne located in the beard distribution. That's very true, but now we're kind of thinking more about it as acne in other parts too. Generally, this acne would flare with your periods, and if you are a kid or a young woman, oftentimes you will have hirsutism, PCOS, or irregular periods with your hormonal acne, and when this happens, I generally get help from my endocrinology colleagues and talk to them about an endocrine workup, so checking estrogen, DHEAS, things like that. Generally, it's recalcitrant to isotretinoin. I think some of these women do get 1 or 2 courses in their lifetime. I think maybe it helps a little bit, but usually it comes back. So often a lot of these women end up on spironolactone, or they end up on some type of oral contraceptive agent that's FDA approved for acne. And nowadays we have clascoterone, which is very, very interesting because now we have a topical agent that could help combat hormonal acne. So let's talk about the increased trend of spironolactone in kids. So in the graph, you can see that the numbers are increasing. So we are seeing more kids get prescribed spironolactone. Generally, it's adolescents who are much older. Because this is happening, we do get a little bit concerned about safety. So when you're going through puberty, there's like changes in your hormones. Sometimes changes are important. So we're not sure about these possible anti-androgen effects on the endocrine development. So because of that, there are lots of studies undergoing. I know the Pediatric Dermatology Research Alliance is doing some of their studies. There are some things that are already published. For example, there was one retrospective study that looked at over 100,000 patients. These patients spanned late adolescence and young womanhood, and these people only had about 0.22% of patients with hyperkalemia. So this is very very suggestive that adolescents will probably have very similar side effect profiles as adults, which is not surprising. And then there was another paper that looked at 80 patients who were aged 14 to 20 years, and these patients, basically they were looking at whether or not they discontinued the medicine, like were they able to tolerate the medicine when they were on it, and the answer was generally yes. So only 3.8% of them discontinued, whereas there was another study that the same group put out, which had more adults, and in the adult group there was 10.4% that discontinued. So it looks like maybe even the kids can tolerate it a little bit more. It's hard to say. It's a very small population, but we're getting more and more evidence every day. Dapsone. This is something else that we often will use for women with acne, so I wanted to touch on it for younger kids too. So pre-adolescents can be prescribed Dapsone as well. There was a recent study looking at 100 patients who were aged 9 to 11. They got Dapsone 7.5% gel on the face and acne-affected areas. There were 17 patients that got maximum use. What maximum use means that they got 2 grams per day for 8 days. This was the entire face, the upper chest, the upper back, and the shoulders. And then they looked at how everyone did. So at 12 weeks, facial acne was clear, almost clear in 47% of patients. That's pretty good. And then there was low systemic exposure, so it was in the nanograms range, which is pretty low. And then the adverse effects were low. There were no or mild cutaneous irritation. However, there was another case report in the literature that was outside of this study that showed a girl who put Dapsone 7.5% gel on her face, chest, and her back daily for 2 weeks, and she said she used enough to cover a toothbrush. And that to me sounds like 2 grams, but maybe she used a giant toothbrush, but she had systemic exposure in the microgram range, which is 1,000 times higher than what they saw in this study. So she actually had severe systemic side effects, had to be hospitalized. It was very different. I just want you to know that this is in the literature. I think generally Dapsone is safe. I tell my patients that it's topical, but there is a small risk for systemic exposure, but just know that this is in the literature. Okay. And then lastly, I do want to talk about transgender and gender diverse youth and some dermatologic considerations. So first of all, gender affirming surgery. So this is a great article that actually gives little tidbits that you can include in your after visit summary. So you can just basically copy and paste this into your after visit summary for your transgender and gender diverse youth. So one of them is for gender affirming surgery. It talks about how there is a little bit of like the isotretinoin surgical risk. It touches on it very briefly, talks about if you're undergoing bottom surgery, you may want to have hair removal before undergoing surgery. If you get surgery, there's always risk of scarring, like hypertrophic scars or keloids, and you should talk to your doctors about them. There's other stuff about testosterone therapy. So we all know that testosterone therapy can worsen acne, and it tells the patients that, well, you can talk to your provider about topical medications, orals, or isotretinoin. Also talks about hair growth with testosterone therapy as well as hair loss. And it kind of lists out some of the common treatment modalities as well. So this is just a quick little tidbits that you can give to your transgender and gender diverse youth. And then acne-wise, I wanted to end on this very scary thing. So most of you know what this is. This is acne fulminans. Most of you are very familiar with this. And it's basically very severe acne that can happen with or without being on isotretinoin. It can also happen basically with or without systemic symptoms. So if you think that your patient might have systemic symptoms, you do want to work them up with the appropriate labs and get imaging if needed. And then of course there's an algorithm, usually with steroids, and then you taper down, and then you also add on a little bit of isotretinoin. Sometimes the kiddos who have really bad acne fulminans will need other systemic agents like adalimumab or cyclosporin or methotrexate. So let's talk about some acne mimics now. So first of all, we have this bumpy adolescent nose. So if you said that this was acne-associated angiofibroma like papules, you got it right. So what is this? So this is actually a single-site case series. There were 20 patients. They were Hispanic males mostly, and they actually got these bumps after their acne went away. And these bumps are actually angiofibromas on the nose and on the chin area, and it didn't go away with acne treatments. They ended up getting erbium YAG laser, and it went away. They did not try to use mTOR inhibitors. So the thing about mTOR inhibitors, we use it in peds derm actually for patients who have tuberous sclerosis and have lots of little fibrous papules or angiofibromas. So they didn't try that, but this is interesting because this is something that looks like acne, but it isn't acne. So beware of these little papules. Childhood rosacea is something I'll just talk about briefly. We see it not very commonly in kids. Probably the most common variant of childhood rosacea we see is periorificial, which is the one on the bottom around the mouth, and you also can get it around the eyes. Childhood rosacea is interesting because you also can get IFAG, which is idiopathic facial aseptic granuloma. Try saying that 10 times fag. I just say IFAG, IFAG. So you can either get kind of single nodules on the face or bigger nodules. And the idea is that these nodules are not infectious. So they're actually a sterile inflammatory reaction. The kiddos who have this, a lot of them will meet criteria for rosacea. So if you have a lot of nodules, your chance of having rosacea increases to 80%. The treatment is generally with oral antibiotics, and you can use an ultrasound to help you with the diagnosis and also monitor. And then just to touch briefly, management of childhood rosacea is very similar to adults. We don't have specific guidelines at this point. We do want to identify these patients because generally it's very, very rare. Most kiddos will have acne. It's the common bread and butter acne. Childhood rosacea is very rare. Usually you still want to discontinue the topical steroids and then start with topical therapies for milder cases and do systemic therapy for more severe cases. So some take-home messages from today. So GWAS now tells us there is a link between acne, hormone levels, hormone-sensitive cancers, and psychiatric traits. Acne severity is associated with family history, being an older kid, having an overweight BMI, and skin type oily. Remember the newbie medications, but don't forget the oldies. Isotretinoin is very helpful in many types of acne, including if you have a higher BMI or a fulminans, and videos are good. Beware the acne mimics, like the fibrous papules, also known as angiofibromas, and childhood rosacea, which you can probably treat them like acne. And then finally, technology is changing medicine. I just wanted to give a little shout out to an article we published recently in JAMA. It's called Management of Acne Vulgaris. It's a review. It goes through a lot of cool stuff. There's some pictures. There's also a box with commonly asked questions. So this paper was tailored more towards a general practitioner. So you guys are, and also subspecialists, because we do talk about some of the new acne medicines. So it's out there. Go ahead and pick it up if you want to. And then finally, thank you guys so much. I think everyone gets pimples, so we should know about them. Thank you.
Thank you, Dawn. That was fun. This is my first time to ever lecture after Dawn, and you did a great job, so welcome. It's not my first time to lecture before Hillary Baldwin, however, so we have kind of been paired up many times. But it's a pleasure to be here, and thank you very much for the invitation, George. I think this might be my favorite meeting. I love the Broadmoor. Does anybody else love the Broadmoor? Right? Okay, we even got a whoo on that one. That's great. Okay, so let's do acne update. This is my conflict of interest statement. And this is my favorite question. And if you've ever heard me talk, you've probably heard me ask this question. How many zits on your face does it take to mess up your day a little bit? I'd like a show of hands, please. A show of fingers, probably. One, right? and nobody ever says 5 or 4 or 7. So my main disclaimer there is be careful what you call mild acne, because if it's on us, it doesn't take very much to become moderate acne. So let's just keep that in mind. I do think one of our goals when we're treating acne now is to not just make acne better, we're trying to make acne clear. You don't want somebody who comes in with 10 zits to get down to 4 and then we say, oh, we have done so good. We have improved this so well. We want to get all the way to clear. So how do we do that? I think first of all, we have to communicate that that's our goal. And my favorite way to do that is I look at the patient and I say, I know you don't want to just be better. I know you want to be clear. That is my goal too, and we are going to work on this together. And it may take more than one visit, and it may take more than one treatment plan, but that is exactly where we're headed. L, listen for clues, okay? Now, I think one of the first things that we want to do is say, do you know why that patient isn't better? It's because they're not doing what I said. And unfortunately, that probably is true some, but there may be other reasons why they're not being adherent to our treatment plan. Maybe they don't like the way a product feels. Maybe they don't like that it stains or bleaches. Maybe it's more expensive than some of the other products. So we need to listen for clues and then make adjustments where we can. E, treat early. This one is key because what are our goals for treating acne? Remember, we're not treating acne, we're treating people with acne, and we want to prevent scarring. Are you really, really good at getting rid of scars? I'm not. We've got to prevent them. Have you ever prevented scars before? If you have treated acne, the answer is yes. Okay, so treat aggressively, that's A. How do we do that? We jump in early, we use more combination therapies, we use more hormonal therapies, we use more isotretinoin, we're treating aggressively, we're doing more prior authorizations, and that's important, okay? If you think it's worth using a medication, but it's going to require a prior authorization, do it, because that's our megaphone back to insurance saying, I think this is important enough to fight for. And you know, we've talked, and I'm so thankful, by the way, to our industry sponsors. You notice that when you come to a meeting like this, how many new drugs we have in atopic dermatitis and psoriasis and acne, by the way, and rosacea. So if you think those things are important, take the time to do the PA. And then lastly, don't resist isotretinoin. We should all be getting to it faster. We should all be using it more than we have in the past. Now, I absolutely love this, and I hope you can see it from where you are. The title of this article was, Are We Getting Our Patients Clear? This was published in the JDD in 2021. And what it does is it pulls together the clear or almost clear from all of these different phase 3 trials. And on the left, you see topicals. Okay, now look at what the numbers are. This does not say that we're getting 16% of people, that we're getting people 16% clear. It says that we're getting that percentage of the whole population clear. Now this is monotherapy, and most of the time we're not going to be doing this as monotherapy in our clinics, but look at the left, it's all the topicals. And avoid the temptation to try to compare these and decide which one you think looks best. Now look at the right. That's the oral medications. And there's one big number on there, there's the 87%. But when you look at the rest of those orals, do the orals outperform all of the topicals? The answer is no. So just take a look at those numbers for just a minute. Okay, so let's talk about some topicals. How often do you use a topical to treat acne? Raise your hand if it's almost every time. Right. The exception would probably be isotretinoin. Let's start with topical retinoids. Topical retinoids are still the cornerstone of treating acne, and we have lots of different retinoids that we can choose from. Why are they the cornerstone? Because they normalize that plugging of the follicle. They're also anti-inflammatory. By the way, do these impact sebum topically? That's a real question. Do these impact sebum topically? No, they do not. And I think that gets confusing because people see that the skin gets dry, but these do not do anything for sebum topically. Okay, we're cleaning out the follicle and we're being anti-inflammatory, and that's really what the retinoids do. So here's a nice little table. We have tretinoin, which is our oldest retinoid. We have adapalene and tazarotene, and then the newest one, which is trifarotene. So tretinoin was FDA approved in 1971. It's still a great product that we use, but let's look down that tretinoin column. There are many different formulations. There are many different percentages that are available. And I would say in tretinoin land, the higher you go in percentage, the more effective you get. But what else happens the higher you go in percentage most of the time? you increase tolerability issues as well. Now, let's keep going down that list. Is tretinoin photostable or photolabile? It is photolabile unless it is manipulated in some way. So if it is micronized, if it's in a microsphere, if it's in a microsponge, if it is microencapsulated, and by the way, those things are not all the same, now it becomes photostable. Is it stable with benzoyl peroxide? The answer is no, unless now, and we're going to talk about this one in just a minute, if it's microencapsulated. But by itself, you cannot stack those two on top of each other. Let's look at adapalene and tazarotene. So we've got different percentages there too. And I would say with adapalene, the higher percentage being more effective. We can't really say that now with tazarotene, and we'll look at that in a minute. Both of these are photostable, and both of these are stable with benzoyl peroxide. And then lastly, we have trifarotene. Now, trifaratene's story has been that it is very specific for that RAR gamma receptor. RAR gamma is the retinoic acid receptor that's found most prevalently in the skin. Now, I gotta say, I'm not sure that that matters that much when it comes to either effect or tolerability. But what it does mean is that you can have your effect, because you're so precise, at this very, very low percentage. So look at the active there, it's 0.005%. And if you've got this very low percentage and you spread it all over a wide surface area, we feel even better about safety. This one is photostable, but it has not yet been studied in the presence of benzoyl peroxide, so you may or may not have known that. But let's kind of go further now than just the molecules. Let's look at some of what's new with the formulations of these products. So first we'll look at the product that's called Twinio. This is microencapsulated tretinoin, not 0.025, not 0.05, but 0.1 microencapsulated, and then the benzoyl peroxide is separately microencapsulated. And that's because of what we just talked about. Tretinoin and benzoyl peroxide together are not stable. The benzoyl peroxide would oxidize and break down the tretinoin. And so they have to separately be microencapsulated in order for these two old friends to be able to hang out together and then to have their effect. Also, the silica shell is not a solid shell around these. It's fenestrated, and it allows the active ingredient to come out at a slower rate, which improves tolerability. And I'm not going to really hone in on a lot of the numbers here because I think they can all get muddied as we go through this. Everything I'm going to show you met the endpoint. So this is clear or almost clear in the two sister studies. This is reduction in inflammatory lesions, and we get down to around 66% at week 12. In one of the two studies, we saw good results at week 2. This is, I hate when it says non-inflammatory lesions. These are comedonal lesions, and we see that we meet the endpoint there as well. This is just one example of somebody who started out with about 90 lesions, an IGA of 4. By week 12, he was down to 15 lesions, and he was almost clear. When it comes to adverse events, go to the very bottom of this. Application site irritation in 1.1% versus 0.4 in vehicle. So there are, and you can look up that list, there are going to be some application site issues with this. We get these new products out, and I want what you want. The first question I always get on any of these is it better tolerated? Well, we don't have head-to-head studies, first of all. But I would say with every retinoid, I still start people Monday, Wednesday, Friday, and then we gradually titrate up the frequency of using the products. So what's the innovation here? This microencapsulation technology that allows these two products to now be used together, and then also the slow release and the improved tolerability because of that silica shell as well. Okay, how about trifarotene cream? Here's the 0.005, so specific for that gamma receptor. The other thing that they did very, very, very well with this, now remember this was also 9 and above, but you had to have moderate acne on the face and moderate acne where? On the trunk, right. And so when we think of trifarotene, this is a cleaf, we think of truncal acne. And I have to say, this one really did change the way I practice because, and I've said this on the podium before, for so long I was just adamant, if you had facial acne, darn it, I was gonna have you on a topical retinoid. But then, if I was really honest, if you had truncal acne, I didn't seem to be quite as committed there to using a topical retinoid. I didn't know that it would work as well. I didn't think it would work as fast. And then I saw the results from these trials and I was proved wrong. And so I've got face on the left, I've got trunk on the right. Look at the numbers. How many were clear or almost clear? 42% in each place. Let's look at inflammatory lesion count reduction. Guys, it's almost exactly the same. It wasn't faster on the face. We need to recommit to using these retinoids on the trunk. And then tolerability, this is on the face. We're looking at erythema, scaling, stinging or dryness and stinging and burning. This is face, so put this in your head because the next slide is going to be trunk. And it even looks better there. And here's some photos. So baseline, we see everybody was moderate here. There were no severes. So we see a success from the face and then one from the trunk as well. So what's the innovation? What do we want to remember with Aklief? It's specific for RAR gamma, which enables it to be effective at this really low dose. It's the first new retinoid, by the way, in 20 years. So tretinoin was 71, adapalene and tazarotene the mid to late 1990s, and then Aklief here more recently. And then this was studied on the face and on the trunk. Okay, tazarotene lotion. I already mentioned this a little bit. We think of as you go within a molecule class, as you go up in percentage, you're going to go up in efficacy. But hold on, what if you can go down in percentage and still be equally effective because of your technology, your vehicle technology? And so all of us, I remember when we first saw this, we were all really kind of stunned when we first saw the data with tazarotene lotion, 0.045% going head-to-head against tazarotene 0.1. Okay, so this is a phase 2 study. It was 210 people. The blue line there is tazarotene. I believe that's my lotion. The red is the tazarotene 0.1 cream. So we have cut the percentage in more than half, and yet we don't see one being superior to the other. And this is the same, that was inflammatory, this is comedones, same thing. So these are phase 2 studies before the 0.045 lotion even goes into the phase 3 pivotal trials. Now we'll look at the phase 3 pivotal trials. And remember that the vehicle that this is in, it's in other dermatologics that we have. It's that honeycomb mesh polymeric technology where the active ingredient stays dispersed throughout that honeycomb mesh. And there's also other ingredients in there that are moisturizing. And Hillary's gonna actually do a product theater about this later, so you can learn more about that then. This was people 9 years of age and older, and of course it worked. And again, I'm not going to get hung up in the numbers here. We're hovering around 60% reduction here, and similar here as well. Tolerability. Okay, so look at this. Whenever we see these graphs, remember the 0 is none on the y-axis, the 1 is mild, the 2 is moderate, the 3 is severe. So we're staying an average, and on the left is scaling and erythema. On the right is itching, stinging, and burning. And what you're seeing is we're staying pretty flat, even in those early weeks where we would expect retinization. But even with this one, I usually start out Monday, Wednesday, Friday, and then gradually increase. So what's our innovation here? Improved vehicle and delivery that allows a lower percentage to be as effective as a higher percentage and yet improved tolerability. Okay, clascoterone cream 1%. I think this has been a really nice addition. This is the only topical we have now that could potentially benefit us from that one of the 4 pillars of treating acne, and that is the excess sebum piece. So we just said retinoids don't do that. This is the only topical that could benefit us there, that could impact sebum. This is a topical anti-androgen, so it has all of its effect in the skin, limited systemic availability there. And so what this means is that we can use that not just in women who have acne, but also in men. And I've kind of had fun recently reminding us that all acne is inflammatory. And really, even though we do see people whose acne may get hormonally triggered some, all acne is hormonal in everyone, whether you're a 9-year-old guy or a 20-year-old woman. Hormones are driving acne. Androgens are driving that sebum. And so if we can block this effect, and before we've never been able to do it in guys, but now we can because we can keep the effect all in the skin. So this was studied down to 9. Dawn told us this is FDA approved in those 12 years of age and older. It is BID, and so as you bring this in, I would keep that in mind. This is a BID drug, and in the studies, about 40% of the people in the studies were men. So please don't, we're so used to thinking of hormonal acne as only in women because what we've had before has been spironolactone and birth control pills. But break out of that and realize this is something that can really benefit our male patients as well. So clear or almost clear here, we get close to 20%. I'm not going to use this as monotherapy. I wouldn't have anyway. And then here we've got about 50% reduction in inflammatory lesions. So our innovation here is it's the first topical anti-androgen effective at the androgen receptor level, minimal systemic exposure, and we can use it not just in females, but also in males. Real quickly, on the horizon, we have a triple coming, and this is kind of exciting in the acne world. So this is clindamycin 1.2%, benzoyl peroxide 3.1%, and adapalene 0.15%, and just real quickly, clear or almost clear, right around 50%. Lesion count reduction, over 75%. This is inflammatory, non-inflammatory, again, over 70%. So, if it turns out to be like this in clinic, we've got something that has some real potential to benefit our patients, and then just some clinical photos there. Okay, and I'm gonna go a little faster here. So sarecycline, this was new in 2018, and I'm not going to go through the data. I just want to remind you, one of the things that we like about this in the acne world is that it's narrow spectrum. And remember what we mean by that. Doxy and minocycline are broad spectrum. We can use them to treat infection. We should not be using sarecycline to treat infection. It's going to hone in on the gram-positive, like C. acnes. It's anti-inflammatory, but it doesn't have impact against. Let's look about 3/4 of the way down. Do you see where it says Enterobacter, E. coli, Klebsiella, Proteus, Salmonella? And then we have these bars. The blue is Doxy, the orange is minocycline, the green is sarecycline. The taller the bar, the worse you are at being an antibiotic. That means your MIC is super high. You're having to use a really high dose to kill these bugs. And so what you notice here is that sarecycline is not very good at treating those gram-negative GI bugs that we're looking at there. Okay, anything new with spironolactone? We're using it more, and as Dawn said, we're using it more in younger patients. I still prefer a max dose of about 100 milligrams in my acne patients. That's because the most common side effect is menstrual irregularities. So if somebody's on a birth control pill, or they have an IUD, or they've had a hysterectomy or something like that, then you can drive your dose up and feel pretty good about that. But if they have periods, you want to be careful driving that dose up too quickly. I would say there's no need to check potassium in healthy women between 18 and 45. There's no evidence of an increased risk of breast cancer in women with exposure to spironolactone. It probably takes about 3 months to kick in. Although good news, there are 2 studies right now ongoing, one in Europe and one in the United States, that are comparing spironolactone 100 milligrams a day to Doxy. And in one of them, it's 100 milligrams a day, and I think both of them the whole duration of the study. And so it's going to be interesting to see, does one work better than the other? Does one work faster than the other? Oftentimes, I overlap them because I think the antibiotic works faster, and then I pull it off and let people cruise along on spironolactone. Most of the time, we're going to be using this in combination. You can use it in combination even with isotretinoin. There was a recent publication in the JAD. This looked at 403 women, and I'm going to just go ahead and jump to my punchline. And so I thought this was really interesting. When I looked at the characteristics of the study population, there was one person in this group who had had a personal history of breast cancer, and then they were given spironolactone. There were 5 who were known to be hypercoagulable, and they were given spironolactone. And then the bottom arrow just shows us that the average time people were on this was 470 days. This is meant to be long-term treatment. It always was, it always will be. But how about breast cancer? We know there's the black box that says in rat studies this has been shown to be a tumorigen, but we have those nice big database studies that look like that this is not a problem in females and women exposed to this. But what about those people who've had breast cancer? And I'm sure you saw this article. Adam Friedman was one of the authors on this. They looked at women who'd had breast cancer, And that group of women then had to have continuous insurance coverage for 2 years afterwards. That would be the most common time period to have a recurrence of breast cancer. And so in that group of women who'd had breast cancer, over that 2 years, they also looked to see how many of them had been given a prescription of spironolactone, and it was 746. And now, the age of these people were between 70 and 79, so these are not acne patients, most likely. But what they still found was in this group of women, spironolactone use was not associated with an increased risk of breast cancer recurrence. And so we're starting to continue to move the needle. Years ago, when we would talk about this, people were terrified to write this if there was like a remote family history of breast cancer. And I think gradually we're becoming more and more comfortable using spironolactone. Spironolactone and clotting, I'll just say briefly here, if anything, this seems to be protective. We know that the other hormonal therapy we use in acne in women, birth control pills, increase the risk of having a thromboembolic event. But spironolactone, if anything, appears to have a protective effect against that. So if you have someone who's hypercoagulable, somebody that you're worried about, this would be a good option for them, not a negative option. Okay, isotretinoin, I've got like 2 minutes and then I'm going to have Hillary talk. So what's the goal for using isotretinoin? Complete clearance. But I'm kind of getting to this point in my life where I'm like, why does the goal for isotretinoin have to be one course? It's just really starting to kind of irritate me a little bit. You know, if you have to do it 2 times or 3 times, fine. I don't know of any increased risk associated with really doing that. And then the other thing we're talking about right now is what about using low dose or maybe intermittent dose or interval dosing? Because if you do that, you get to minimize side effects. You get to minimize those dry lips. Maybe we do better on TikTok if we do that. I don't know. I will have to tell you, I've never been on TikTok, and I'm going to try to keep it that way. But you know, I think maybe there is some room for improvement there. But I will tell you, you know, right now people are saying, do we treat until people are clear and then we go another 2 months? I don't know what the specific answer is. I will say I still think there's a cumulative dose that's too low. I would still want you to really try to shoot, in most cases, for 120 mg per kg as your bottom number. The top number is fuzzy. If you want to go longer than that, that's fine. But even when we go high, people are still going to relapse, and it appears that it's about 20 to 30% of people. The characteristics that make you more likely to relapse are being young, male, sometimes you'll see female listed too, the severe acne, females with something like PCOS, people with large numbers of comedones, some people are just going to relapse. Low dose, again, we're going to hear more about this, particularly in patients who cannot get pregnant. Why not do 2 or 3 pills a week and do it more long term? So that's something I think we're just thinking about in the isotretinoin world. And then something that I've only done one other time in an acne talk, device-based treatments for acne. And I am conflicted here. This is a product I've worked with, and I do have this device in my practice now. This is the new Cutera device that was just FDA cleared in March of this year. Interesting, it's a 1726 nanometer laser that goes in and just really eats up the sebaceous gland pretty much. And so what's interesting is you do 3 treatments 4 weeks apart, and then what you see in the pictures there is we have this person at baseline with moderate acne, and then we see him 6 months after his 3rd treatment, and he's improved some, but then we see him 2 years after his 3rd treatment. And he did not do anything else other than the laser. So we need to get more data on this. There is a second one coming. That's what this is. This is another 1726. This is a cure. It is not yet FDA cleared. It is 2 to 4 treatments as well. But some really nice durability here, because we're seeing this person again 3 months after treatment and then 2 years after treatment. So it may be that it's really going to be a change in the acne world with some device-based treatments. But I will stop there. Thank you so much for your attention, and I will welcome up Hillary.
Okay, so let's switch gears a little bit to rosacea. As usual, I can't see over the lectern, so I'm going to stand over here. So we're going to talk about what's new in rosacea in 2022. And these are my disclosures for today's presentation. I have to start off with psychosocial. I know some of you are saying, yeah, I get it. Our patients are suffering. But it always bears repeating. This was a study, very interesting. 2,500 people were asked to look at a whole bunch of pictures of people with rosacea that was digitally superimposed on their faces. And they were given a list of words and a list of concepts to apply to the person they were looking at. Now, they didn't see both pictures, so they didn't know that it was digitally superimposed. They didn't know that this was without and this was with. It was the mean at the end. So the mean results for these words that you see here between the two groups showed that they felt that the subject sitting in front of them was more likely to be insecure, unhealthy, more likely to be single, less confident, less happy, less fun to be with, less stressed, less intelligent, less successful, less reliable, less likely to be in a position of authority, and oh my gosh, could you do something about your face? And I mention this because patients often come to me and say, you know, I don't like going out, I don't leave the house because people are looking at me and they're judging me. And being empathetic souls, our first thought is to say, oh, that's not true, you're a lovely person. People aren't judging you. Well, yeah, they are. Right? So these poor patients are judging themselves and feeling bad about themselves, but they're also being judged by everyone else. So don't poo-poo this concept and make sure that you pay attention to the psychosocial aspects, because not everybody is held back by their bad rosacea, but most of our patients are being held back by their disease. So now let's talk just for a second, I promise, about pathophysiology. All the way over on the right, we know that we're talking about the cathelicidin pathway, grossly aberrant in rosacea, very highly upregulated, and incapable, basically, of telling the difference between self and foreign. All of this resulting in an extravasation of all sorts of inflammatory cells. But what we don't talk about very much is over on the left, which is barrier dysfunction, brought about in part by matrix metalloproteinases and reactive oxygen species that are increased in the pathophysiology of rosacea, resulting in an increase in itch and burn and sting. So we have to recognize that rosacea is definitely a barrier deficiency disorder. Transepidermal water loss is increased, stratium corneum hydration is decreased, and patients as a result have symptoms of itch and burn and sting. We know that improper skin care has been shown in numerous studies to worsen both the inflammatory and the vascular lesions of rosacea, and good skin care results in improvement of rosacea signs and symptoms even without therapy at all. And some studies that showed that if you make the skin better, they can actually use the medications that they couldn't use because they burned and stinged. So when you're making your plan for your patients, it behooves you to make sure that they're using good skin care, because whatever regimen you're using is going to be even better, and the patients are going to be even happier if you make sure that you discuss sunscreens, moisturizers, cleansers, and also cosmetics. Don't forget those. So let's look at treatment in particular then. What do we do if a patient walks in with primarily papular and pustular disease? What product are we going to pick first? Well, I base my decision on severity of disease, but I also, very importantly, base it on what the patient tells me they are willing to do. You really need buy-in in rosacea. They've got a lot of different aspects of disease, and and it's a chronic disorder, right? So you want to have them buy into it. Do they want topicals? Do they want pills? Do they want both? We have the advantage here of being able to give them whatever it is that they want in papular and pustular disease. The newer FDA-approved topicals like ivermectin, minocycline foam, and microencapsulated benzoyl peroxide, as far as I'm concerned in my practice, has completely replaced the older metronidazole and azelaic acid, unless the insurance companies are refusing to pay for these newer products. And then I use a lot of sub-antimicrobial dose doxycycline as well, either by itself or in combination with the others. Any one of these medications can turn these patients into near clear, if not clear, within a 2 to 3 month period of time. So they work extremely well. We're very, very lucky with our papular and pustular disease armamentarium. So let's start by quickly taking a look at minocycline 1.5% foam. Obviously, minocycline, a well-established molecule. It turned 50 last year. Multiple mechanisms of action of decreased inflammation, global rates of resistance remaining low despite it being 50 years old. It's been shown to be orally effective in rosacea, but of course, minocycline has rare but very significant side effects when used systemically. So we've been trying to formulate this into a topical preparation for a long time. It took 40 years to figure out how to do it, and it involves mineral oil in the vehicle. Highly effective. We see here the reduction of inflammatory lesions, study 1 on the left, study 2 on the right. And we're talking about 60% reduction. And look at the slope of that line between baseline and week 4. This is a rapid improvement in the inflammatory lesions. Let me back up for 1 second. We note a relatively small delta between the active ingredient in the vehicle here, and that's partially because of the mineral oil that's present in the vehicle for this product. Mineral oil is an excellent way to repair that barrier that is deficient in our rosacea patients, and is probably part and parcel of the activity of this drug. So the vehicle, I think, in this drug in particular, really helps with the efficacy of the product. It also helps with a reduction in tolerability problems. Look at the tolerability list for the cutaneous tolerability, virtually 0, thanks to that mineral oil. So the question always is, and Julie and I could talk about this for a long, long time, when we first heard about this drug, we said, oh, no. I'm not using minocycline without also using benzoyl peroxide. I'm not going to destroy this great drug. I'm not going to make it what happened to clindamycin, or even worse, erythromycin, happen with my favorite drug for the treatment of both rosacea and acne. So what we didn't realize is shown on this slide. This is a graph of the rate of evolution of drug resistance versus drug concentration. And we're all familiar with the MIC, the minimum inhibitory concentration. When you're below that, you may or may not be killing off all of the organisms. But we're not quite so familiar with the MPC, the mutant protection concentration, above which you have so much drug that you're killing everything. The sensitive organisms, the resistant organisms, the first mutant organisms, so much drug that you kill the whole darn thing. It's in the middle that you run into problem with resistance. So this particular medication floods the epidermis with minocycline. There is a ton of product on the surface of the skin, but very, very little absorbed. The difference in the skin between a pill of minocycline and this foam is about 750-fold. Same story for in the systemic circulation. The oral medication obviously giving you a lot in the systemic circulation, and the minocycline foam giving you just barely quantitative. So you can see in the body, hardly any, in the skin, a whole lot, at both ends in the area in which resistance is unlikely to occur. And indeed, spontaneous mutation frequencies were shown to be about 1 in 100 million. So apparently we don't have to worry that much. But if you're still worried and you still want to use benzoyl peroxide along with your minocycline, you might be saying, that's a great idea, but I sure can't do that with my rosacea patients. They're too irritated. They're too easily irritated. Yes, there's some data that shows that benzoyl peroxide is effective in rosacea, but it's way too irritating, right? So along now comes microencapsulated benzoyl peroxide. Now, Julie just told you about Twinio. It's its kissing cousin. It's the same mechanism of action. The benzoyl peroxide has been encapsulated inside a silica shell. So you take the crystal, you coat it with a cationic surfactant, and then you dip it in a bowl with anionic silica monomers, which snap together like a magnet onto the surface of the surfactant, giving you this silica shell formation. And then you could repeat that. Stick it back in the surfactant, stick it back in the silica as many times as you want, creating excess layers on top of it. It ends up being sort of like a cabbage head, where the benzoyl peroxide is in the center and all the leaves of the cabbage are surrounding it. Now, the medication can eke out through the microchannels between the leaves, giving you a very slow delivery of benzoyl peroxide onto the surface of the skin, as opposed to that big bolus that caused the irritation with prior formulations. So you end up with efficacy without the tolerability problems. So here we're looking at efficacy, absolute mean inflammatory lesion count, study 1 on the left, study 2 on the right. And you can see between the two, about 69% reduction of inflammatory lesions at the end of the study at 12 weeks. But look at the slope between baseline and week 2. These patients have lost more than 40% of their inflammatory lesions within the first 2 weeks. That makes for a very happy patient, and very happy patients make very happy doctors, right? And they're also much more likely to be utilizing their medication so that they're more compliant with therapy and ultimately do much better. So that jackrabbit start, I think, is very important. IGA success rate over time, almost 50% between the two studies. And you can see a nice big delta between the active and the vehicle with statistical significance between the two occurring as early as week 2. What about tolerability? Well, we usually look at tolerability because what we're worried about is that the product that we're using is going to cause tolerability issues. Well, it didn't cause tolerability issues, it solved them, as you can see here. These patients have rosacea. They come in with all sorts of itching and burning and stinging at baseline, which actually resolved with the use of the medication, as opposed to the medication causing problems. So this is not new. The sub-antimicrobial dose doxycycline came out in 2006, but I got to mention it because a lot of you are new, and this drug has not been promoted in a long time, and to my way of thinking, it's still one of our most crucial drugs for treating rosacea. This is a non-antibiotic dose of doxycycline for a condition that does not have an organism that requires killing, and that is a chronic disease which is going to need a medication for a long period of time. I feel very strongly, as you can probably tell, that we should not be using full-dose medication, tetracyclines, to treat this disease. The plasma levels are not high enough to become an antibiotic, purely anti-inflammatory, not creating ecologic mischief, therefore safe and appropriate for long-term use for our rosacea patients. How does it do this? Well, it has 30 milligrams immediate release beads and 10 milligrams delayed release beads. The 30 brings it up to snuff in the plasma levels, and then the 10 takes care of it over time so that it does not drop down rapidly, gives you a nice, long, adequate plasma level for anti-inflammation. This is the quintessential slide for this drug. We're looking at plasma concentration over time. That dotted yellow line represents the antimicrobial threshold. The green is 50 milligrams of doxycycline. And as you can see, 50 milligrams of doxycycline exceeds the antibiotic threshold, and it is an antibiotic dose, whereas the subantimicrobial dose in the teal is well below the antibacterial threshold. So lots of people say, what's the big deal? 50 milligrams of doxycycline, 40 milligrams of doxycycline. You know, how much difference could it make? It could make a lot of difference. It's the difference between an antibiotic and a non-antibiotic for a condition which is not infectious in nature and chronic. So making sure that your patients are not on an antibiotic dose, I think, is crucial. If I can't get this dose, I use 20 milligrams twice a day of doxycycline. However, it needs to be used twice a day. It cannot be used both of them together. The pharmacist will tell them 40 milligrams is 40 milligrams. Well, 40 milligrams of immediate release doxycycline is an antibiotic dose, or it's very close to that antimicrobial threshold. All right, sarecycline for rosacea is a thought that just came up a couple of years ago. Tetracycline antibiotics, as we know, well documented for the treatment of inflammatory lesions of rosacea. But since 2003, we've been focusing primarily on the subantimicrobial dose doxycycline, again, because of the absence of antibiotic resistance. But sarecycline has been shown to have a very narrow spectrum of activity. It's got 16 to 32-fold less activity against the gut bugs than does minocycline and doxycycline, so theoretically causing less mischief. And spontaneous mutations for this drug have been shown to be less than 1 in 10 billion. So it appears that sarecycline is more narrow spectrum and less likely to create ecologic mischief than doxy and minocycline. So in a 12-week placebo-controlled investigator-blinded pilot study of 102 people with moderate to severe inflammatory rosacea, sarecycline was used at its appropriate dose of 1.5 mg per kg per day. And what they found was that the IgA improvement was statistically superior in the treatment group compared to the vehicle, placebo, with a nice big healthy p-value, as you see here, a reduction of inflammatory lesions superior at 4, 8, and 12 weeks, and a significant reduction in burn, erythema, and pruritus without any serious adverse events. So just for a few moments, let's talk about vascular disease. So in our patients with pure vascular disease, background erythema, the hallmark of rosacea, we need to make sure that we're differentiating between the facial redness that you can see in rosacea. It's critically important. We have patients with this persistent facial erythema, which is the hallmark of rosacea, where they're red most of the time. They might wax and wane a little bit, but they're red most of the time. Then we have people who flush, who go from nothing to bright red in a few seconds. Then we have people with perilesional erythema, where the redness is just surrounding each and every one of their inflammatory papules. Now, if they have enough inflammatory papules, like in this photograph here, they look as if they've got background erythema, but it's basically just the merging of the perilesional redness. This kind of redness goes away with the appropriate treatment for papules and pustules, and does not go away with alpha agonists that we'll be looking at in a second. Nor do telangiectasias get better with the alpha agonists. These vessels do not have smooth muscle completely surrounding them and will not respond to the alpha agonists. So very important to tell the difference between these, because with persistent facial erythema, we're looking at alpha agonists or light and laser. For flushing, maybe beta blockers. There's not a whole lot that we can do for these patients sometimes. Some of my patients feel that the alpha agonists reduce their flushing as well. For perilesional, we're talking about drugs. For papulopustular disease and for telangiectasias, we're talking about laser and light. So crucially important to distinguish between them. So we have two drugs that are alpha agonists, oxymetazoline and brimonidine, and as you see here, they bind to different receptors at the neurovascular junction, with oxymetazoline found postsynaptically only and brimonidine in both locations. So not surprisingly, they act slightly differently. And I'm always asked, which one is stronger, which one is better, which is the one that you're using? How do you figure out which one to use? Well, which one is stronger? I don't know. There's no head-to-head between them. If we look at the pivotal phase 3 trials and compare them to each other, which we know is kind of dirty pool, right? Done on different people at different times in different ways. But in this particular case, the study was exactly the same, set up exactly the same fashion. If we looked at just 2-grade improvement at 3 to 6 hours, it appears that brimonidine is a more effective drug. But that is a 2-grade improvement. That's what was required by the FDA for the phase 3 trials. Here we're looking at baseline on the left, a grade 1 improvement, and a grade 2 improvement over on the right. I can't really tell the difference between 1-grade and 2-grade improvement. So if you look at both grade 1 and grade 2 and you put them together, both of these drugs are way up in the 60, 70, 75% of patients reaching at least a 1-grade improvement, which I think they would be quite satisfied with. Brimonidine might be a little bit faster onset, but I think oxymetazoline is a little bit longer lasting. So which one is stronger? You know, it's sort of up in the air. You're going to have to figure that one out for yourself, but I think each one of them has particular benefits. The flip side of the coin is which one has more adverse events. Well, they're both extremely well tolerated. You know that brimonidine ran into a little bit of a problem in the beginning because they were promising no rebound, but a lot of things were wrong with that study, not the least of which is that they told patients to use 5 pea-sized amounts on their face. 1 is perfectly adequate. And if you prepare the skin, prime the skin, by repairing the barrier first, you don't see nearly as many problems. So personally, I think they're both very well tolerated, but oxymetazoline appears to have less of a problem with worsening of erythema, or as I prefer to call it, rebound erythema. What about when patients have combination disease? What do we treat first? This is a picture from the brimonidine long-term safety trial. So you can see all of the erythema that she has at baseline pretty much went away at 3 hours. But now, wow, can you see those papules that you couldn't see before? I have this picture in my office, and I show it to the patients, and I say, which one of these women would you rather look like? And I'm here to tell you that about 50% of the people pick red, and about 50% of the people pick pimples. A lot of women say, you know, those pimples embarrass me, so I'd rather get rid of them first. But you don't know until you hand the patient a mirror, point out all this stuff to them, and ask them what they would prefer. Don't put yourself in their shoes. There's one study that said, let's treat them with both from the very beginning. It was a 12-week study, ivermectin cream every day, and then brimonidine was added either from the get-go, so they used brimonidine in the morning and ivermectin in the evening, or they waited a month. Let me say that again. They waited a month before they started the brimonidine. There was no increased irritation thanks to adding them both starting in the very beginning. And there was, of course, improved reduction of erythema because they were using the brimonidine, right? The weird thing that happened was that they also looked at inflammatory lesion count. And here you're seeing the inflammatory lesion count, the patients who were clear or near clear. The vehicle is in the orange. The blue bar in the middle is when brimonidine was used for 8 weeks, and on the right is brimonidine that was used for 12 weeks. Well, there should be an improvement with erythema with brimonidine, but why the heck did the inflammatory lesions do better when brimonidine was used for 12 weeks instead of 8 weeks? Does brimonidine have anti-inflammatory properties? Maybe it does. There's a couple of in vitro studies in mice and in humans that suggest that maybe it does. But the other question is, do alpha agonists have disease modification abilities, or do they just make you unread that day? Well, in the long-term study for oxymetazoline, we did see some disease modification. These two pictures over on the right are the same guy day 1 before he was dosed, and on the last day of the study at week 52 before he was dosed. Obviously, on day 1, he's got erythema, otherwise he wouldn't have been in the study. But look at week 52. He doesn't look as if he has any erythema at all, and he hasn't had the drug applied to him yet. So he has had some disease modification. Here's the mean of that. It wasn't just him. Everybody saw that. The green is in hour 3, and the pink is hour 6. And you can see that as time went on, the patients did better and better and better and better. Now look at the purple bars. Those are pre-dose. What the heck? They didn't even, at 1.2, I can't read the numbers, 5.5 and 11.2% of patients were clear before they had the medication put on. So clearly there's some disease modification. There are things about the alpha agonists that I think we don't know. But it does beg the question, should every rosacea patient be treated with both vasoconstrictors and anti-inflammatory agents, regardless of their phenotype? I think maybe yes. All of our rosacea patients have inflammation. All of them have vasodilation. Inflammation causes neutrophil recruitment. Neutrophil recruitment, when they come in, they release nitric oxide, which causes vasodilation, which causes leaky capillaries, which causes release of pro-inflammatory cytokines and neutrophils, which produce inflammation. So I'm very much looking forward to seeing if this pet hypothesis of mine turns out over the years. Thank you very much for your attention.
Alrighty, team, great job. Question?
I'm just curious, do you all look at comorbids with rosacea? And do you feel like down the road it will be does treating the drug help reduce the comorbid question like psoriasis?
Right. I include those questions in the entry form that the patient fills out. I found that asking patients if they have cardiovascular disease, gastrointestinal disease, creates a whole lot of anxiety, and we still don't know if there is a correlation. The correlation that's the highest so far is for small intestinal bacterial overgrowth. I think that is real. So I do ask general questions about it. And if I look through the review of systems and they have a lot of GI symptoms, then I may ask them about it. What do you guys do?
Similar to you, I don't routinely ask about that, and I think because so much of this we don't have a cause and effect, and we can't answer that question that you very importantly asked, which is if I can control the disease inflammation, am I going to actually help those other things? Just personal story here, my mother has rosacea. She's also had basal cell carcinoma, Parkinson's, and so when I look at my own mom, she actually has several of the comorbidities that are listed. So I find it personally very interesting, but I don't go too far down that line yet because I can't do anything about it.
Right.
Okay, we've got a bunch of questions and little time, so do you use carvedilol and for flushing erythema in rosacea, and if so, what dose, how long?
I certainly do. I use carvedilol. I start at 6.25 milligrams twice a day and then gradually titrate up to 12.5 milligrams BID. I have one person, though, who uses 6.25 milligrams a day by itself and does great.
Hillary?
I follow what Julie tells me to do.
Okay.
She has so much more experience with that than I.
So for Medicare patients who get Mirvaso or Rhofade, do you ever try Afrin off-label, and what is your regimen?
I have tried that. You just hold your breath, close your eyes, squirt it on your face, and hope for the best. In some people, it works. The vehicle is not great. It's kind of irritating. So if you're going to do that, I'd make sure you do barrier repair for a couple weeks first.
So there's a question about minocycline foam. How do you manage sort of like a little bit of a greasy and yellow residue? How do you manage that?
It's not so much of a problem in the rosacea patient because they're older and they sort of appreciate the grease, but in acne, not so much.
Yeah. Well, you know, I was curious when I first started using it whether or not people would like it. And I have to say, I don't know if maybe I've just set it up right. My patients actually liked it. They used it at bedtime. Now, the 4% is more yellow than the 1.5%. So that's one way you could get creative. I won't say too much more about that. But if somebody's really bothered, you could always try the lower percentage. I also totally botched it when I first started using it because I told people to use like, you know, a gumball amount. And boy, once you really play with that stuff, I think we're back to a pea. It doesn't take very much, and a little bit goes a long way. So the yellow, you're going to mess up your pillowcase probably. The oily, I think people end up liking if it's used at bedtime because it helps them to tolerate the dryness that's coming from the retinoid that they're using.
So Dawn, how low will you go in age on prescribing spironolactone, and do you adjust the dose?
Usually, I think most of the girls who come see us will probably be 16. Sometimes they will be 14. It really depends on when they started having their periods. So oral contraceptive agents, we don't start until about a year after menses because of the bone density issue. And then oftentimes we will also put girls on OCPs along with the spironolactone because of the risk of the teratogenicity risk. Of course, in kids, it's a little bit different because sometimes you believe it a lot more when they tell you they're not sexually active.
Very good. How do you incorporate clascoterone twice a day into a regimen with other topicals, including retinoids? How do you mix the two?
Yeah, and I do think it has to be BID. If you've felt it, it's pretty creamy, so it's going to be going on second. So, for example, you're using a retinoid at night, I would do clascoterone twice a day, but the retinoid would go on first at night, and then the clascoterone on top of it is the way that I've done it. Now, if you push me and say, has that all been studied? I would say no, but it's been done in Birmingham, Alabama, and probably in other places too.
And Brooklyn, New York.
And Brooklyn, New York.
I
And
do that
maybe
too.
San Diego,
Yep.
right.
We do that too.
Hawaii, too.
And Hawaii. Yeah, there you go.
But you'd have to come and inspect the property. Anyway, ladies, thank you for your brilliance. I learned always a heck of a lot and appreciate you all. Thank you.